Most patients with an osteoarthritic knee will need a bespoke plan for them, depending on how this is manifesting and affecting their everyday quality of life. There are some non-surgical options, which include physiotherapy and prehabilitation, where a master physiotherapist will make sure that the joint is moving in a good way and is supple, because having a supple joint, even though the joint is worn out, improves the results of surgery later on. The injectable options, where one can inject steroid or lubrication or any stem cell type solution, can reduce pain and swelling for a few months, but very often isn't the cure. Finally, surgical options ought to be considered once the condition affects the everyday quality of life, and one would carefully choose between a partial knee replacement and a total knee replacement. In reality today, the word knee replacement can be changed for a resurfacing procedure, as essentially what we're really trying to do is to resurface the worn part of the knee. This is a partial knee replacement, resurfacing a 1/3 part of the knee. Colloquially, people refer to partial knees as half knees, but in essence, they are a 1/3 replacement of a worn cartilage surface. This is a very good option if the other 2/3 of the knee are well preserved. And these days, you can make sure that that is the case by getting X-rays, MRI scans, and very carefully examining the patient to make sure that the other parts are well preserved. In my practice, 10 to 20% of patients may be suitable for a partial knee replacement. But the key is to get that decision-making right so that it is a permanent solution for them. This implant here is what we refer to as a total knee replacement. In reality, what one is doing is to replace the worn surface of the knee with a metal and plastic surface, rather like a dentist would crown a tooth. And this could be referred to as a total resurfacing of the knee rather than a total knee replacement, which sounds a much more scary term. What one is doing is removing the damaged part and sculpturing the internal parts of the knee to take a bespoke, custom-fitted surface on the femur, on the tibia, and also lining the back of the kneecap. And that then allows the patient to really function very well in due course once everything is healed.